first speaker has already been partly introduced by Olav already, but I'm very glad that Nikhil Munshi has come all the way from the US to Oslo, and he will also follow us around in Norway for this week to talk at the patient seminars. He, as Olav told you, is a professor at Harvard Medical School. He's a senior physician at Brigham and Women's Hospital and Boston VA Healthcare Center. He has a long track record with clinical trials in the US and will today talk to us about insights into the novel frontiers of myeloma treatment. Nikhil, the word is yours.
Thank you very much, Tobias, and thank you, Frederick, Olav, and Cedar for having me here in this wonderful country. And this is my first visit to Norway, believe it or not, and it's been really joyful to be here and looking forward to more. So I'm going to talk more about new frontiers, but sort of more on the clinical side with some research directions of where we are going. These are my disclosures. So in myeloma, as Tobias said, we have great new advances. If you look in the United States, we have 19 new drugs approved in the last 20 years, almost one new drug a year. It's more approvals and more access to drugs than any other cancer in general. And if you look at the graph on the right side, we are on to a path that in this decade, 21 to 30, we would expect 15 more drugs, or 6 of which are already approved in this last 2-3 years, and many more to come. So there's been great progress. And again, as Tobias said, the field has changed. Our progression-free survival, patients live longer, even with their first treatment. Overall survival is more than 10 years, and it's increasing. And this is because of the new drugs, combinations, and how we give it in certain succession. And there are 3 eras: the transplant era, the targeted therapy era, and now the immune therapy era. So my focus a little bit will be on immune therapy because that has become quite an important component of what we do. But to start out, what's the goal of treating patients with myeloma? And what has happened now is that getting MRD, minimal residual disease negativity, is our very important focus. This was a little bit older, couple-year-old. In myeloma, 2 years is an old time. Analysis of 8,000 plus patients. And you can see on the left side, the PFS, the 3 curves on the top are patients who are MRD negative, the 3 bottom are who are MRD positive. And the important point here is that I'm sure you have heard about needing to get MRD negativity as a main response for newly diagnosed patients. And we try to look for it, and I'll be happy to answer questions on it. That's one of my areas of interest. But the important point is that is the top green curve, 71.8%. That's relapse refractory patient. And what this tells us that it is important to get MRD negativity in newly diagnosed, but it's equally important to get it in relapse patients, because if you get MRD negativity, the relapse patients would also do as well as what we do with newly diagnosed patients. And so the focus for all patients, newly diagnosed or relapse, is to get MRD negativity at early stage or late stage. And you can see on the right, it impacts very significantly. You can look at the below, relapse refractory. If you get MRD negativity, it's incredibly effective in increasing the complete remission rate. So this is the preamble to the rest of the talk, that we need to keep an eye on how we get MRD negativity. And a very important point is that patients who are MRD negative, their outcome, high risk or low risk, is similar. So we have this concern about high-risk patients, whether they would do well or not. But if they do get MRD negativity, their outcome, the top 2 lines, are very similar. So again, even to overcome the risk stratification, we would try and get MRD negativity. Now, there are a few new things that are happening as far as these response measurements are concerned. So MRD is the ultimate, it's important. MRD requires bone marrow. So are there alternatives that can either help us do less bone marrow or supplement the bone marrow? So one of the things is mass spectrometric examination of the blood protein. And this was a very nice presentation and a publication recently that was an analysis of over 750 patients, and it compared the mass spec measurement of protein versus the traditional immunofixation. And what it shows in the top curves is that IFE is good for induction and transplant, but during the consolidation, IFE is not as important, just because it is not sensitive enough, most likely. On the other hand, if you do mass spec negative versus positive, the middle curves, they separate quite clearly for all the subgroups. So having ability to detect more closely, more sensitively, gives us a better differential of who is going to do well versus who is not going to do well. And if both are negative, mass spec and IFE, those are the patients who do well, the bottom curves. And so one of the important newer development is some analysis using mass spectrometry for response. The second one is circulating tumor cells, and there is really great amount of emerging data. This was one of the studies from my institution, but there are many other coming where patients at diagnosis have, in the significant proportion, circulating tumor cells. Very small number. But now there is technology exists that even if there is small number of cells, we can purify them, we can analyze them, and based on their presence or absence, we can prognosticate. And not only that, but using those cells, we can also analyze their genomic changes, genomic content. And so detection of CTC and its immune profiling to monitor the disease is very important. It can also be done as a follow-up. However, it is not a very good assay to duplicate and or replace MRD measurement. So this is more prognostic, not for response to a large extent. And finally, one of our colleagues at Farber, Dr. Lohr, did this study with us where he looked at the cell-free DNA. So that's in serum. We don't need bone marrow, but you can take patient's plasma or serum, both are fine, and then analyze it to look for circulating DNA that may be coming for tumor. And it's very informative when patients do not have circulating tumor-free, cell-free DNA, the top curves on both sides, those patients have much better outcome than not. And so all these assays are developed. They're not yet validated enough, but they probably might help us decrease the number of bone marrow we may need. So till this assay becomes negative, maybe I don't need to do MRD assay, for example. So these are the developments that are going to change how we follow patients for their response and then follow-up prognostication. Now coming to treatment in newly diagnosed patients, we have many drugs and we have many combinations. Triplets, whether it is RVD or VCD or KRD, these are quite standard, and they still are standard in large number of places. However, they are being replaced by the quadruplets. And quadruplets include the same triplets with one of the antibodies, either it is daratumumab or isatuximab. And so antibody plus the 3-drug regimen seems to be a new standard of care in this disease. So how has that happened? It's happened based on a number of studies. So one of the earlier studies done by our French colleagues was compare daratumumab with Velcade thalidomide dex versus VTD. Thalidomide was used because at the time when the study was done, there was standard of care in the French area. And this study clearly shows that patients who get 3 drugs on the left side have much better outcome compared to those who get 2 drugs. And you can see that with 3 drugs, you could see significant number of patients getting CR and also getting MRD negativity. So if you look at VTD data, there is reasonably close to half, a little bit less than half of the patients would get MRD negativity, and their outcome, the top purple curves, are also quite significantly better compared to 3 drugs. So here we are comparing 4 drugs versus 3 drugs, showing this result. A non-randomized study, but very well-known, is the Griffin study that came from Dana-Farber. Jacob Laubach published it. It's comparing 4-drug regimen, DARA, Revlimid, Velcade, Dex, DARA, RVD, versus RVD. And it was a phase 2. That's why I said it's not randomized in the sense that it is not phase 3 study. But the phase 2 clearly shows the difference that patients who get 4-drug regimen, the purple bar, are significantly better results, both MRD at a 10 to minus 5 threshold and MRD at 10 to minus 6 threshold compared to RVD alone, clearly establishing that 4 drugs do better. And then the survival outcomes similarly are mimicked on the right side. So clearly, this study shows, even though phase 2, that 3 drugs are not as good as when we add daratumumab to that combination. And then there is a more recent study, which was called MASTER study, where daratumumab was added to carfilzomib, Revlimid, Dex, and it showed that, and this was a complex study. The purpose was not to show that 4 drugs work better. It was presumed it is good, but it was a question about when can you stop the treatment. And the point was that if you get MRD negativity on 2 successive occasions, maybe you can stop the treatment. And in this study, it showed that if you do not have high-risk feature or only one high-risk feature, then you could stop treatment and patients do equally well. But if you have 2 or more high-risk features, then probably that's not adequate. So it tells us how long to treat these patients on maintenance and or continued induction. So this is sort of a laundry list of all different studies done with 4-drug regimen. And the point is that you could see that patients have high CR rate, almost 50 to 70% patients get CR. And if you look at MRD negativity, 30 to 50%. And so we are reaching, in this case, in many cases, not all patients, without even transplant, you get complete remission in between 30 to 50% of the patients. So we go halfway even without adding high-dose chemotherapy. There is special emphasis for high-risk patients because that's where we need to get MRD negativity. And the 4-drug regimen have been piloted in 2 different studies and many more going on to make a point that if you use 4-drug regimen, you can achieve a very good response. So this particular study was DARA KRD followed by a transplant, more DARA KRD, second transplant, and maintenance. So very complete study. Smaller study, 40 patients or so, 48. But response rate is 96%, which is now very common. But MRD negativity rate was 62%. So even in high-risk patients, now 60% patients get MRD negativity when transplant is included. And I think that's very profound. Those 60% patients will have outcome hopefully similar to as if they did not have high-risk disease. And second very well-known and large study is this concept, the German group study led by Sonja Weitzel and Lisa Leopold. This is where patients get isatuximab, carfilzomib, and Dex. Again, same concept, antibody, proteasome inhibitor, immunomodulator, and Dex. And this similarly planned, but in this study, there were patients who were not transplant eligible. They also went on the study in a separate cohort of the patient. And what it shows basically is that overall response, 95% with transplant and 90+% VGPR. Transplant ineligible, 88% with 88% VGPR. But 67% were MRD negative in transplant eligible, 54% in transplant ineligible. So again, even in high-risk disease, 2/3 of the patient are now becoming MRD negative. And that's where we want to get, and that's where this kind of combination is getting us. So this is becoming, 4-drug is becoming standard of care for high risk for sure, but in our practice in most of the places in the US, it's becoming standard because that gives us the best possible depth of response with best possible outcome. So then what is the role of transplant? Because with all this new drug, if we get good MRD negativity, do we need transplant? So this determination study was one of our studies that came from Boston. It was a US-wide study, and also we partnered with the French group here. So it's IFM DFCI 209 study. Half of the patients got 8 cycles of RVD, followed by Revlimid maintenance, not for 12 months, but for indefinite time. On the French side, it was 12 months. And on the right side, patients got same RVD but had transplant. So the question is, what is the role of transplant when you use RVD? And the study very clearly showed, it's a little busy slide. Basically, it shows that patients who got transplant, this group, had significantly better outcome compared to those who did not. And the numbers are quite 67% is the PFS, almost 6 years. This is compared to the French study, where the same numbers were 47 versus 67. Why the difference? Because on French, there was 1 year maintenance. On the US side, it was indefinite maintenance. So indirectly, although not randomized, it tells us that indefinite maintenance provides better outcome. But clearly, this study shows that PFS with transplant, the red curve, is significantly separating from the rest. However, the interesting feature here is that even with 8 years of follow-up, overall survival curves are still overlapping. And so we have to still wait and see how do these patients do later on. Now, one important thing that is happening in myeloma that's important for us as physicians, important for patients, also important for our regulators. And we have discussed this with the FDA in US, is that overall survival is not a useful endpoint in myeloma anymore. And the reason is that everybody, even the people in blue curves, a number of them ended up getting a salvage transplant. They all get CAR-T or some such treatment, bispecific, etc. So from the initial randomization, 10 years later, whatever happened in the middle, we cannot judge the impact of what we did in the beginning 10 years later with whatever 5 different treatment patients may get with all different access and different things. So the good news is the curves are overlapping. Not so important news is that overall survival for outcome of drugs and randomization is becoming less and less important. Now, one of the important things we did in the labs, Dr. Mehmet Samur from our group, he looked at the patients to see what does transplant do to the myeloma genome, because melphalan that we give for transplant is a toxic drug in the sense it's a cytotoxic drug. It can damage DNA. So when patients relapse, is the myeloma genome much more complicated? And the answer was yes. So you could see that these are the 2 curves. These patients are not transplant. These patients are transplanted. This is a diagnosis. Both the groups have very similar mutation, as you expect. However, when patients relapse, in the non-transplant arm, there were 2,000 more mutations. Sounds a lot, but it's not. However, on the transplant side, there were 6,000 more mutations. So it tells us that giving high-dose melphalan induces more mutations in myeloma cells. That's very critical because you can see the red curve, the increase in number of mutation is very different curve for transplanted patient versus blue curve, which is non-transplanted. And this is important because you would intuitively think that having more mutation is bad myeloma. And maybe we should be doing transplant or not. So before publishing this paper, we looked at every possible data we could find from all our colleagues and friends across the globe. There's no study that clearly showed that doing transplant and relapsing from transplant leads to more aggressive myeloma or a bad myeloma. They do quite well. So the mutation increase is correct, but they're not doing well is not correct. So what's happening? So one of the interesting things we found in our analysis was that when patients relapse from transplant, because of the mutations probably, there is a significant increase in neoantigens. Because of the mutations, new antigens come up, myeloma cells might become more immunogenic. And maybe that is why, after relapsing from transplant and with more mutation, they're not doing so bad. They do respond. And these are the times when we are beginning to do immunotherapy, as you will see in a minute. And so maybe that is the flip side of having more mutation with transplant, but in return, it might make myeloma more immunogenic to treatments we utilize. So this is transplant-eligible patients, then transplant-ineligible patients. Same algorithms applies. I wouldn't go into details of which drugs are here. Triplets have been standard, but now we are beginning to use quadruplets as well because the theory, and I'll show you data, the initial data, that theory that old patients, frail patients, should get less treatment is not accurate. In fact, they quite often do well with same good treatment that we give it to so-called younger patients. And so now the trend, even in patients who are 70 and 75 and beyond, is to begin to think about giving 4-drug regimen based on certain other features. So there are 2 very well-known studies done which quite clearly establish that 3 drugs are better than 2 drugs, even in transplant-ineligible patients. The MAIA study very clearly showed, very strongly showed, that patients who get daratumumab, Revlimid, Dax have a significantly better outcome, 62 months, compared to those who get 2 drugs, Revlimid, Dax, the blue curve. And even with small number of patients relapsing, there is an overall survival benefit significantly. So that's very clear. On the second side, in Boston, Betsy O'Donnell published this. We did a study of what is called RVD light, where patients got the same 3-drug regimen we give it to younger patients, except instead of twice-a-week Velcade, these patients got once-a-week Velcade. And the Revlimid dose was decreased from 25 to 15. And what it showed was that even with this dose reduction, the response rates are very similar, 90+%, and their outcome is quite good. In all comers here, it was a smaller study, but everybody was included. And so bottom line is that these patients with either dose-modified RVD or DARA-RVD do very well, and these have become, this 3-drug regimen, RVD or DRD, have become standard of care. One of the studies very recently was published a week ago, again from our group. Clark Dumontier published this, I think it was just a few weeks ago. And it was a very interesting study. It was a study of 2,800 patients. These are the patients who got either RVD or RD. And this was not randomized. This is whoever got whatever physician's bias and whatever way look at it. However, what it showed was that if you look at non-frail patients, mildly frail patients, and moderately severely frail patients. So moderately severely is where I want to focus. And if you look at the hazard ratio, it's actually improving for the patients who are getting 3-drug versus 2-drug. And what it tells us that even though patient may be quite moderate to severely frail, and frail definition is another complicated thing, but they might even do better by getting 3-drug rather than 2-drug. We intuitively, if somebody is 80, we would say, let's give 2-drug. That's not true. Those patients might even benefit more, and we have to monitor toxicity, et cetera. But this is a very interesting study that will add to why we should do more in the older or frailer patients than less. Unfortunately, it looks like most of the patients relapse. And I hesitated saying that because I think with all the newer treatment we are doing, with getting 60, 70% MRD negativity, I think number of patients may not relapse for a while, and they may not need any subsequent treatment. But those who do relapse, we have to look at how do we manage these patients. So very many features are to be considered. Frailty and age, and you're going to hear about some of that a little bit later. You have to look at what disease morbidity, renal failure, whether patient has bone disease, etc. We have to keep that in mind as we decide the relapse treatment. We have to assess the risk of patient is a high risk or not, because if it's high risk, we want to be more aggressive. And then lifestyle, patient's preference, travels, whether they can go to a hospital every week or not. Those are important points. But the critical point, after saying all these things, what really matters is what did patients get before, and then what are the choices next. That basically drives the main decision influenced by all these other factors I mentioned. So again, we have a long laundry list, and I wouldn't go through the list, but depending upon the availability of various drugs, we have many, many combinations. There are at least, after giving the first 4 drugs, we still have 15 more drugs to go to treat relapsed patient populations. So how do we decide? Basically, as I said, depending upon what patients have received before. So carfilzomib and pomalidomide are the 2 very proximal possibilities. Both are very effective. Carfilzomib works when Velcade doesn't work, POM works when Rev doesn't work. They're good combinations. There's a combination with carfilzomib and Cytoxan that one can give, and so on and on. And so a number of studies have been done in relapse, and those are the names of the trials. And these are all regimen with either RD backbone, PD backbone, or in some case, KD backbone, carfilzomib dex. And each of these studies shows that 3-drug regimen, even in relapse setting, provides better outcome. You can look at overall response. Almost all of them have superior overall response compared to 2-drug regimen. They have superior progression-free survival compared to 2-drug regimen. And wherever they have looked at overall survival, in majority, it has been in the right direction. So basically, even in relapse patient, we should use 3-drug regimen, not 2-drug regimen. I wouldn't prescribe any one because it depends on what patient had before. So if you look at one example, carfilzomib dex with daratumumab, the CANDOR study, you can see the PFS is so significantly different here, 15 versus 28 months, almost double. And so clearly, these are one of the good possibilities to be used in relapse patient population. After we use this, what's new in the pipeline? And one of the newer drugs that stay tuned for it are the 2 immunomodulators, or the newer version of Revlimid and pomalidomide. One is mezigdomide. It was just published in New England Journal 2 weeks ago. And there is a cousin of it, iberdomide, again, very similar drug. Both iberdomide and mezigdomide are the newer immunomodulators. They're more effective. Toxicity, we still have to wait once a large number of patients get, because initial toxicity from studies are not always as accurate or as reliable. But they are well-tolerated drug. Cytopenia remains an issue, but quite effective. So in patients who have had lots of previous treatment, exposure to all standard myeloma drug, overall response rate is 40%. And even in patients who had prior anti-BCMA therapy, the last curve, the overall response rate is 50%. And so very effective treatment, including almost 1/3 of the patient being able to get those who respond, they get complete response. And so 2 new drugs, stay tuned. Those would be added to the approved drug in hopefully in next one or 2 years. But what has changed the world is the immunotherapy. And BCMA is the center of our treatment right now. Why is BCMA so important? Because it is only expressed in myeloma cells and the normal plasma cells. It's not expressed on any of the blood cells you can see here. So plasma cells, myeloma cells, maybe late B cell, but the rest of them are predominantly negative. There's some question that low-level expression on normal stem cell, et cetera, that's more for research. Practically, it does not matter a whole lot. And the second thing is that BCMA has some signaling characteristics. So BCMA binds to 2 of the ligands, either BAF or APRIL, and through that, there is activation of NF-kappa B, which makes myeloma cells survive. And so this interaction suggests that myeloma cell is a little bit dependent on BCMA. So it is not easy to lose BCMA and become resistant. Although I'll show you an example, that does happen. So because of this, BCMA has become a very important target. Now, there are 2 major CAR-T studies done and approved in the United States. I think one of them is definitely approved in Europe, and the second one is also, CARVYKTI is also approved in Europe. So both APEC-MIND and CARVYKTI are approved. What are the results? Now, these are the patients who are very advanced disease. The patients had median of 6 lines of treatment. One of the patients, I think, had 21 lines of treatment. So we wonder, what are the 21 lines? But when you have 19 approved drug, if you do mathematics and do a permutation combination, we can come up with 21. So in this very advanced patient population, refractory to all last treatments, overall response rate at the target dose was 81%. PFS at the target dose is a little over 12 months, and overall survival is a little over 24 months. So this is very advanced. In same patient population, when they get standard of care treatment for not getting CAR-T and others, these patients' PFS is around 3 to 4 months instead of 12 months here. And their overall survival is around 9 months instead of 24 months. So unbelievable prolongation. If we look at the results of Cartitude, Carvykti, or Cilta-cel, the other one is ide-cel and Abecma, here the response rate is 98%. Only one patient out of 97 did not respond. The second one was also borderline. But basically 98% response rate. And more importantly, 82% of the patient got complete remission, even as the 6th line treatment median. So that's an incredible response at a late stage. And if you look at progression-free survival, it is 36 months. We just had an update of this a couple months ago in EHA, that the overall progression-free survival is 35 months, 3 years. And overall survival, the median hasn't been reached yet. But if you look at 3 years PFS, 3 years OS, it is 63%. And so very deep response, and response lasts for a very long period of time. Now, these treatments can be given to elderly patients. The oldest patient we did CAR T-cell recently was a little over 82, did sail through very well. So it can be utilized at a very wide age range. Unlike transplant, which is up to 65, here I think the age limit is very much changed. And you can see that between 65 and 70, the response rates are very similar. And the toxicity is not significantly increased. And so we have to keep that in mind, that it increases response, not the toxicity. So now the CAR Ts are coming earlier on, because if they're so effective as 6th line, can we bring them earlier? And so there are 2 studies presented and published. One is the KarMMa-3 study, which is ide-cel with standard of care regimen in patients with 2 to 4 lines of treatment. The previous one was more than 3 lines, so between 2 and 3 lines. And you can see that the patients with ide-cel get significantly higher CR, 39 versus 6, and also the rest of the response. And the PFS is significantly different, 13 versus 4 months. So you could see that PFS increase in this patient with standard of care is quite significant. Cartitude-4 patients were 1 to 3 prior lines, so even a little bit earlier than KarMMa-3. And again, if you look at CR, 31 versus 28, 21% CR. Very big difference in depth of response. And similarly, very big difference in PFS with a hazard ratio of 0.26. And so both of these treatments says that treating patients early is going to be important. However, we are continuing to follow to see, does CAR T improve, early CAR T cell improves the outcome. And you can see that PFS in patients at the 12 months versus more than 12 months, how long they're followed and what their prior regimens are, can affect their early use or not. So if you look at patients, Cilta-cel with 1 prior line of treatment and Cilta-cel with 2 to 3 prior lines of treatment, the curves are overlapping. So should we give it newly diagnosed? Should we give 2nd line or later? That question still needs to be answered. It's very clear that getting early and a deep response is going to give us a good outcome. Toxicity, I won't go into too much details of it, but having done this for now 6, 7 years, toxicities are not what we thought used to be. Everybody gets CRS, 90+%, and you can see in 5 to 6 different CAR T studies, these are the 2 what I talked about, and these are other CAR T studies, either early stage or different product. They all have between 75 to 95% CRS. Majority of them are grade 1 and 2 that can be easily managed. It's a very small number of patients have higher grade, and usually the higher grade is connected with higher disease burden. So if this patient has a high disease burden, we can give something else, bring it down, and then can do safe CAR T cells. Neurotoxicity, again, it's around 15%, much less than what we observed in lymphoma. And again, it's all low grade. Very few has grade 3 neurotoxicity. There was some concern about Cilta-cel having this late neurotoxicity. However, managing the disease burden and early recognition of any of the late side effect has mitigated those problems. The problem that I would be very careful, so I'm not worried about CRS, I'm not worried about neurotoxicity. The toxicity that we have to be cognizant of and careful is cytopenia and infectious complications. And that's what we have to give prophylaxis for. Patients need to get IVIG. Almost all of them need IVIG because their B cell functions are quite significantly suppressed. They get acyclovir, they get Bactrim for infections prevention. So infection prevention it's preventable, so that's a good news, but we need to be proactive there. Next question is CAR T cell. It's so expensive. Can we afford it? And the point is that there was an analysis done. There's a big group as part of the Harvard system, the ICER group, and its name is like ICER, but they do big analysis of all the treatment for cost effectiveness and their expertise. So, and the way it is analyzed, and I wouldn't go into detail, maybe Sonia would know this, but it's called QALY, Quality Adjusted Life Years. So what they look at is if you give a treatment, how long the patient lives, and what is the price for that. You can put price to a year. I had a patient who was 75-year-old and got a BACMA. She was 9 months or so in the clinic getting IVIG, and she saw me, she called me, and she held my hand and said, "Thank you. Because of your treatment, I was able to see last month my grandchild." And you can put price to that. So, but still, we have to know the price. And what the price for CAR T is $112,000 per QALY gained. And that's how they measure it. But to put it in perspective for myself and for you too, when we patients get Dara-RD, and if you think the price of Revlimid, which is more, is brought down or everything, Dara-RD, QALY is $152,000. CAR T is $112,000. And if you look at Selinexor VD, the same ICER analysis is $480,000 QALY gain. And so in putting in this perspective, it's not so expensive. Yes, the first time price is high, but then there is nothing. Patients don't get maintenance, they don't get any treatment. They do get Bactrim and acyclovir, but they're not getting Revlimid or Dara or some maintenance. And so I think there is something to it that it is probably not as costly. It's like transplant. You know, one of the cheapest treatment right now is probably transplant. Everything else is much more expensive. So we have to keep that in mind. And then to make things even more interesting, we have bispecific antibodies. There are three of them approved. Majestic is teclistamab, and to make it just succinct, it gives 63% response rate in the same population who have had median of 5 or 6 lines of treatment, extremely effective treatment, gets reasonable amount of MRD negativity, around 25%. That's a bispecific MRD negativity. And it is also well tolerated. The toxicities are same, CRS, neurotoxicity, cytopenia, and infections, but they're all of low to moderate grade. The second bispecific approved is elrantimab, response rate 64%, so quite effective. The dosaging are different between the two. One is once a week, the other one is twice a week, but they're all being modified now to make it less frequent so that it is easier for patients on one hand and decreases the side effect of immunosuppression on the other hand. So these are the two approved bispecific available to us for utilization. But if you look at the list, and this is a partial list, there are lots of bispecific out there, each with around 60 to 70% response. So that's important. They all work at a very high level in advanced patient. And the toxicity would be infection, which happens in anywhere from 35 to 55, 60% of the patient. So same issues. The last three, talquetamab and cevostamab, has different target, and I have a little bit details on each of them. So what has changed in myeloma? The previous 7 drugs, when approved before 21, 30% response. You take pomalidomide, carfilzomib, all the good drugs, the drug that is standard of care for now. And 30% response was good enough for the drugs to get approved. What has changed in the last 2 years? The 5 drugs approved now have a response rate that is anywhere from 65 to 95, 98%. So the whole algorithm has changed, how much we accomplish with this treatment. And that is a great excitement, that we have access to drugs now that can really change the outlook. And this is a very important component of what we do. But this is not enough. Till we cure the last patient, we got to do better. And so there are lots of improvements in the works for these patients. How can we make CAR T better bispecific better. We are improving the product, the box in the blue. We are trying to increase the expression of the antibody, the box in orange. And then we are trying to treat patients or appropriate patient at an appropriate time. So the box in green. And all these things are going on. I wouldn't go into details of that, happy to answer questions. But the important point is that because CAR T cell resistance can develop, there are many more targets that we and others are looking at. We have large genomics data, so we have more targets. We can make more CAR T cells. So that's one of the things. The second thing is that CAR T requires the production. So when you make CAR T cell, you take patient's cells, apheresis, it's sent into the lab. Lab takes around 8 weeks to prepare CAR T cells. Then they're sent back to the hospital and they're infused. So patient has to wait for 8 weeks. And patients do not have time to wait 8 weeks. Quite often when they're ready for CAR T, late stage, 8 weeks is too long. We have to give something else. So now there are newer efforts, and this PHE-885 is one of our collaboration with Novartis, where Dr. Sperling from our group is leading this effort, where the CAR T cells are now produced in 2 days. It's even less than 48 hours that it can be very quickly produced. So vein to vein, it could be less than 7 days to administer or so. And it is very effective as well. It's the effectiveness of the target dose currently looks like anywhere from 95 to 100%. And very importantly, the type of cells that are produced and the type of cells that grow in the patient after infusion are very favorable. They are the T memory cells or T stem cell-like cells. And those are the cells we want to get better killing and very importantly, better persistence. So I think we have to keep that in mind. So that's one improvement. The second improvement is alternate target. So talquetamab is a bispecific that targets GPRC5D. It's a different target. We'd also have a clinical study on GPRC5D CAR T. So there will be another CAR T hopefully approved in near future. Now, this is also very effective. It's 73% effectiveness, and it is also late-stage treatment. The one side effect to keep in mind for this patient is that GPRC5D is expressed on the skin and the cuticles and others. So patients get rashes and cutaneous problem, the nail problem, and also have problems with smell. That really bothers the patient. But still, they're not severe grade. They can be managed with local treatment, local creams, and local steroids. And patients do respond, and that's the good news. And again, we are learning to change the dose, how best to mitigate it. And the second drug is cevostamab, which is another target, FcRH5. So one more target, one more treatment. This has also been used in large number of patients now, showing 50+% responses. So hopefully, one of these days, this can become available as well. So there is this now concept, or evolving concept of total immunotherapy. There used to be total therapy for cytotoxic drug. Now this is where we will have induction that combines a lot of drugs, but more immune targeting. There's an immunomodulator, whether it's iberdomide, mezigdomide, or one of those. We have ICD, which is immunogenic cell death inducing drug. Even bortezomib is ICD-inducing drug, so that fits the criteria. The consolidation probably would be with CAR T. So instead of transplant there are at least 3 or 4 ongoing studies that are head-to-head comparing transplant versus CAR T. And we'll have to wait and see the results, but as we predict, I think CAR T will induce more MRD negativity and it will become an important component. And then maintenance might be with bispecific. So that's a flow that we are thinking. I'll give a very quick glance of the future drugs. So all these immune drugs are great. What else is in pipeline? So one of the targets that we are, Dharminder Chauhan from our group working with Ken Anderson, we are looking at alternate ways of inhibiting protein degradation. One of the target is RPN10. There is a drug that looks like very effective in mice. You could see the survival in mice is increased, the tumor size is decreased, and you can see very small tumor size here. And this is one of the drugs that we believe will go to clinic targeting RPN10. And the second one is work that is going on in my lab, and Eugenio Morelli is leading the effort with me. It is targeting a whole new molecules called long non-coding RNA. Again, for those of you who are interested in this subject, would love to talk. And this is an area where there's so many possibilities. More people join would be great to fast forward this. But earlier, Mehmet Samur, almost 5 years ago, published that there are many. There are at least 62 long non-coding RNA which are unique to myeloma that are dependent on, myeloma is dependent on their growth. One of the targets we named MIR17HG, or we are calling it RROL, RNA regulator of lipogenesis. That one has a very unique mechanism of action. It is an RNA, but it allows the two proteins to bind. So MYC and WDR82, these two proteins have to bind together, and then that bound protein will do whatever it does in the tumor cells to continue to grow. And this binding does not happen unless this RNA is present. So RNA is like a sandwich that allows these two proteins to bind. In absence, it doesn't bind, you don't see the changes. So you can see that when we develop the inhibitors for this RROL or MIR-HG, the tumor in mice in a very short time is significantly inhibited. Now we have small drugs and everything targeting one of the 62 long non-coding RNA. So we need 62 more people in the lab to work on each and find new drugs. And so to conclude, I think the plan is to deliver the best tolerated, most effective treatment as an initial therapy, not to keep something for later. I think the best first punch is the best treatment to go to. And these are the combinations we have talked about. Earlier use and improved efficiency, improved effectiveness, and availability of CAR-T and bispecific are going to be important part of our treatment, and with new targets and everything. And if patients do relapse, we need to treat this disease at an early evidence of progression. And so what is our ultimate goal? Is to attain persistent MRD negativity, not one time, but more than once, and to have a normalized immune system. And I think with those two together would be potentially a cure, which we are almost there. So thank you very much.
Are there any questions to Nikhil directed to the talk now? Fredrik?
Thanks, Nikhil. It's very good to have you here and show all this stuff. I just have a question regarding the bispecifics, where they're all moving from even bi-weekly to monthly, and they are all doing it. So the question is, you can look at this as only mitigating toxicity, but you can also look at it as potentially prolonging the efficacy because T cells don't exhaust it. So if you were to take an educated guess, do you think that going to monthly with these drugs after the induction phase and so on, will that lead to the same efficacy, better efficacy, longer, or a shorter?
Yeah, no, that's a very good question. So we are currently doing studies, and as you say, we are all currently in a haphazard way, making it every 2 weeks, every 4 weeks. I mean, I like every 2 weeks, so I go 2 weeks and somebody does 4, and no real scientific rationale. It is our gut feeling. So what we're doing study currently is for two purposes, and that's exactly, I think, what you are alluding to, which is, one is, what is the right longer interval we can use? And can we decide that based on some immune parameters? And what you, I think, were mentioning is that by decreasing the exposure to bispecific, we can also improve the exhaustion phenotype to more natural phenotype. And so giving a break, let the T cell recover, and then give it again when it will work equally well again like it used to be in the beginning, would be the whole plan. So one thing I would hope that changing the dosage at some point might end up being driven by some immune profiling. In general practice, that may not be as easy because this requires all the expertise. So the hope is that based on these initial results, we might be able to judge, are there patients who should get it every 2 or 3 weeks versus patients who can go 4 weeks. This is both to make it convenient, less toxic, but also very importantly, like you said, more effective because the T cells become better and then we can use it more frequently. I mean, for a longer period of time.
Because I think a practical issue here is that the regulators that calculate the ICER, how much does it cost per benefit? When we say that, we say to them, we can give it every 2 weeks instead of every week, and we get the same efficacy for a much less cost. They say, that sounds good, but we don't know that, so we have to calculate with the weekly.
So I think there are already studies done with the commercial use where we have all given. So for example, in Athens meeting, we presented data from Dana-Farber with 56 patients who got commercial CAR T-cell. I mean, commercial bispecific teclistamab. And this is where we decrease the dose in some of the patients. So now that sub-analysis will be published, and others are doing similar, that clearly would demonstrate, or is demonstrating, that decreasing does not change the efficacy. It decreases the cost for sure, it decreases the toxicity, and it still maintains the efficacy. So this, I think, analysis is just around the corner. I think we know that it's actually not even for money purpose, even for patients' toxicity purpose. It's very important to make it every other week, or even less, because elrantimab is every other week. So that can be made into every 4 weeks or something. That data doesn't exist clearly, every 4 weeks, but there are studies by company and by all of us are ongoing. For teclistamab, we already know that every 2 weeks appears to be very similar after getting the initial best response. So we have to wait till we get good response, but then we can make it less frequent, affecting price, toxicity, and also response.
And how long is that, if you were to say generally?
So that is also a very important question. We don't know the answer to that. How long we need to give? So in the world of lymphoma, they don't give it. They stop cold turkey at various time points from 9 months to 18 months. And I don't treat lymphoma, so I don't know the nitty-gritty details of it. But they don't give it forever. And when patients relapse, they restart it, and they do get efficacy. So it's possible that we can give it for a certain period, and I can't give you the exact number today, but at a certain point we can stop it and give it, or give it so infrequently that it's the benefit of stopping is gained without losing the efficacy because we stop totally.
Thank you.